Good afternoon, everyone. My name is Lisa Osqui. I'm a Senior Program Manager at PCMCH. Thank you all for joining us today at the PCMCH webinar series for the Pediatric Diabetes Network and the Ontario Pediatric Bariatric Network. Before we begin, please note that toward the end of this webinar, we will have dedicated time for Q&A. So feel free to type in any questions you may have at any point during the talk in the chat box provided or located at the bottom of your screen. And we will get to as many as possible at the end of the talk. With that said, it is my privilege to introduce you to Nicole Gehring and Dr. Geoff Ball. We're going to talk to us about multidisciplinary pediatric weight management, focusing on insights learned from the team to address bariatric care in Canadian children. So Nicole Gehring is a senior program lead with the University of Alberta School of Public Health in Edmonton and holds a Master's of Science in Health Policy Research. Her research includes health system services, policies with health system services and policies with a particular focus on health and social equity. She works closely with service providers, health authorities, governments to identify, evaluate, scale systems for improving health outcomes and advancing health equity. Dr. Geoff Ball is a professor of pediatrics and the Alberta Health Services Chair in Obesity Research at the University of Alberta in Edmonton. His research applies diverse approaches to generate, evaluate, and apply new knowledge to optimize obesity management and prevention in children and families. In partnership with Obesity Canada, he's working with a national committee of parents, clinicians, and researchers to update Canada's clinical practice guideline for managing pediatric obesity. So with that said, I'd like to give a very warm welcome to Nicole and Geoff, and we'll pass it over to them to begin their talk.
Well, that's a wonderful introduction, Lisa. Thanks very much. And thanks to all of you for participating today. I'm going to start off and then we'll transition to Nicole partway through. But before we get into that, we'd like to make a land acknowledgement. So thanks, Nick. And Nicole's going to be transitioning the slides here, so we'll try to do our teamwork effectively as we go through. But to start off, the University of Alberta acknowledges that we are located on Treaty 6 territory, and we respect the histories, languages, and cultures of First Nation, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Thanks, Nick. So this is what we thought we'd do today over the next 20, 25 minutes or so, is to talk about the CIHR team grant that Nicole and I and many of our colleagues led over a series of years. And then we'll talk a bit more granular about a couple of the projects that we led during that time. One around predictors of enrollment and referral to multidisciplinary weight management clinics. And also we'll talk a little bit about exploring how healthcare professionals can support families with respect to multidisciplinary pediatric weight management. And I think there'll be some, although the focus is obesity, those of you who work in diabetes know there's a lot of overlap between the sorts of issues that we experience clinically and the families that we see in our clinics. So hopefully there's good crosstalk here between those two areas. Thanks, Nick. So before we started today, Nicole and I haven't chatted for a little while, and it was a bit nostalgic for us to think back to the work that we did a number of years ago. This is the protocol paper we published back in 2017. So we started the work certainly before that. And all of that work was preceded by a meeting that Obesity Canada, the Canadian Institutes of Health Research, and I think Heart and Stroke at the time, a few other groups. It was around 2011 or 2012. They had a meeting in Montreal. They brought a bunch of folks together who had done obesity research and stakeholders, and they wanted to do something with respect to obesity. So in terms of funding, research related stuff. So they ended up deciding that they were going to allocate funding for team grants to bring folks together who do obesity research and clinical care across the country. But I mention this because it was, at least in my experience, was a seminal moment for the work that we do in Canada in obesity, because there were individuals with lived experience with obesity who spoke at the beginning of the session and shared their stories and experiences, and you could hear a pin drop in the room when that happened. And for those, maybe you started in the field in the last year or 2 or 5 years, that's pretty common now. Back in the day, it was very uncommon, but it really set the tone for the conversations that were had at that meeting, and has informed a lot of the work that those of us in the field have been doing this for a number of years. So, but what came out of that was they were going to have money for 3 team grants across the country, and we knew early on there was probably going to be 1 pediatric. They probably weren't going to fund more than 1. So what a group of us did is we sort of self-organized, and we said, okay, let's put in a real kick-butt project together. Let's work together. And it was a nice opportunity for us to build rapport and trust and relationships that's led to the work that we continue to do on the clinical practice guideline, that the work is ongoing, and other projects. So this project that we'll share with you today was really important for a lot of us academically in our careers, but more importantly for the clinical work and the things that we're doing clinically with families. And if anyone is interested, if you want to skip the whole talk and just look at all the information we have online, if you check out teamabc3wordpress.com, all the infographics, all the publications, all the stuff we've done over the years, it's all there. And Nicole did a wonderful job of keeping us organized and on track. So it's a nice nostalgic record, at least for us, the stuff that we did. Next slide, please, Nick. Thanks. So this is what the grant was. We focused on 2 areas. One related to understanding issues related particularly to severe obesity in children, and also to evaluate a couple interventions with respect to managing severe obesity in children. So, and I think in the end, it was around 1.5 million, which is a lot of money. But in terms of big team grants with people across the country doing multiple projects, the money gets spread out pretty quickly. So I think we were pretty efficient with the resources that we had. And you can see the projects that we have here. We're just going to talk about a couple of them that I mentioned already. But again, all the information that you'd ever want would be on the website. Thanks, Nick. And these are things that we did along the way. So we'll get to the data. I'm sure some people are just really keen on data, but there's a little bit of a story that leads to the data. So we had annual general meetings. We had office hours where we would have trainees who would attend the general meetings, and then we'd do this matchmaking to try to get learners connected with faculty, to build community and to build mentorship and those sorts of things. So we did a lot of sort of team-related things to build that connection. And that was what our office hours was really about. We also, through the grant, we provided awards for trainees to actually attend the meetings as well. And these are not big, they're not hundreds of people. They're like 30 or 40 people could make it. And we'd have, share. This is pre-COVID, of course. There's no masks in any of the photos. But it was a great opportunity for us to get together. We had an external advisory panel. We had colleagues from the US who were leaders in the field. They would give us feedback and share their perspective to help us do what we needed to do. We had projects proposed initially, and then we ended up adding a project because there was an opportunity through the Canadian Pediatric Surveillance Program to look at severe obesity and global developmental delay, and Nicole had a lead role on that project. So it was very, we had a proposal, we did the things that we said we would do, and then we did a little bit more, which is a nice, you sort of under promise and over deliver, which is a sort of a good feeling for us at the end. Go ahead, Nick. So we published a number of papers, obviously based on all the projects led by folks in different places, and the infographics we shared through social media. Obesity Canada was a really good partner for us, helping with the dissemination of information. Thanks, Nick. Next one. And these are all the people that were involved. I think we might be missing a few students that contributed along the way. I think we might have had 6 or 7 master's and PhD students who used data from the team to help to contribute to their graduate degrees along the way. But we had fairly good, not necessarily coast to coast to coast, but pretty good representation of a lot of the leaders in the field of obesity management and prevention across the country. Thanks, Nick. All right. So the project that I'm going to spend a little bit of time on relates to some research that we did in Alberta. So the 2 images on the right, these are papers, these are qualitative studies that we published before this team grant. We did a multi-center qualitative study where we interviewed families, Vancouver, Edmonton, Montreal, and Hamilton. These are families who were referred for weight management. Some attended, some didn't, some dropped out. We wanted to understand their experiences, and the qualitative data that we collected from families was really formative because it led to this quantitative study that I'll talk about related to referrals. So we know the recommendations for children with obesity should be referred when the services are available. for pediatric weight management. The interventions generally focus on lifestyle, behavioral, and psychological changes. There's been a lot of stuff in the media lately around pharmacotherapy and surgery. Maybe we'll have some discussion with that at the end, but primarily in Alberta, we were talking about, at the time, lifestyle and behavioral and psychological changes. We know from some evidence that intensive interventions can be effective to help boys and girls improve their weight and their health. And we know from these qualitative data that there are issues that families have, experiences they have, some that we sort of would expect and some that were a bit of a surprise to us, that impact their decisions to enroll and also whether they stick with it longer term. So we were interested in exploring a little bit in more detail predictors of referral and enrollment in Alberta. Next slide, Nick. So this is the paper we published in Journal of Pediatrics. I think it's 2018. It was led by Arnaldo Perez, who was a PhD student of mine here in Edmonton at the time. And of course, lots of folks, both academic and clinical and sort of from the health system, participated in helping to make this possible. So the first thing we wanted to do is to characterize those kids who were referred for pediatric weight management and to quantify what proportion of those boys and girls actually who were referred actually enrolled in care. And then we wanted to dig a little bit deeper to look at some of the factors that may predict whether or not boys and girls actually enroll in treatment. So this is looking back at administrative data that were collected through Alberta Health Services. You can see the time frame there. These are all the boys and girls that were referred to one of 3 pediatric weight management clinics in Alberta. So there's 2 in Edmonton at the time, and there's one at the Stollery Children's Hospital, one at the Misericordia Hospital, which is out by the West Edmonton Mall, in case people are familiar with Edmonton, or the landmarks in Edmonton, and then Alberta Children's Hospital, which is in Calgary. And we had a data analyst at our local Women and Children's Health Research Institute help us with our analyses. So I'll orient you to the slide. So the data in the total column, that's everybody. We had about 1,900 boys and girls referred for pediatric weight management over the study period, which I think was 3.5 to 4 years. The next column is those boys and girls who enrolled. The last column is those boys and girls who did not enroll. So just descriptively off the top, one of the things that stood out for us was material deprivation, which I won't get into the details, but it's more or less a measure of socioeconomic status. So resources that families have. And what we found is that in general, those boys and girls who did not enroll tended to have greater deprivation. So they had less financial resources. The other thing that is probably not a surprise to many of you, depending on where you work, is that geography mattered. So those families that lived in urban settings were more likely to enroll than those families who lived in non-urban settings, which would be a lot of rural and remote communities. So that was like the first pass descriptive sorts of analyses. Next slide, please, Nick. So our first objective, one of our objectives was to look at, well, what's the proportion of boys and girls who actually enrolled in care? Just under 40% of those who enrolled, which is not that different from other studies that have been published in the US and other places. But it just highlights that referral is not enough. There needs to be some things along the way that we'll get to that will hopefully help boys and girls and families engage in their care. Thanks, Nick. So this might be a little bit difficult to see, but the next step for us in our analysis was to look at the univariable predictors. So looking at them one at a time. And we found, not surprisingly, again, that material deprivation was important. We found anthropometry was important. So those boys and girls with severe obesity, they tended to be less likely to enroll. Procedural things mattered. So the wait time between when boys and girls were referred to actually when they had an appointment at the clinic, that mattered. And then there was an interesting thing related to season. So summer and spring, there was something interesting going on there. So the table on the left is basically looking at everything individually. But I think what most people want to know is, well, when you consider all of those factors, what really matters? And that's the smaller table on the right. So when we factor in all the things that we could measure, the things that mattered were the time gap. So model 1 includes both weight status and time gap. So this is the weight status of all boys and girls. Everyone's included. And so when we include everybody, the wait time matters. So the longer the wait time, the less likely families were to enroll in care, which is it's an interesting thing to find because that's something that we have some control over. We can orient our health services to try to limit the amount of time or reduce the barriers or hurdles or the things that families need to do to get into the clinic. When we did some subgroup analysis with about 400 boys and girls, we looked at those boys and girls with severe obesity exclusively. Time gap still mattered to that group, but for those boys and girls with severe obesity, the higher their BMI Z score, so the heavier they were within that category, the less likely they were to enroll in the clinic. So it highlights for us that it's not just about the time or the service, it's about those boys and girls who present to the clinic and the features they have and who may be at increased risk of not participating in service that may be beneficial for them. Next slide, Nick. So a few take-home messages here. What we've learned through this and some other quality improvement work that we've done is it's really helpful for families if we can simplify the enrollment process, reduce the demands that often are well-intended to try to get information from families or to make sure that they are, so they can demonstrate motivation or whatever we think it's about. If we can simplify it and shrink it so that it's short, that's better for families. If we can provide support to help families initiate treatment, and that can be through other things that we're doing related to parking. We've got a project related to family navigation to help families navigate the healthcare system. Those kinds of things seem to be helpful. And just to make it as easy as possible for folks to access care. And the recommendation to refer all eligible children and families for care if boys and girls present with obesity still holds. If only 40% of people were referring actually enroll in care, there's the 60% who may not enroll now, but may enroll later. We've done some other analyses on repeat referrals, and it seems like if you have that conversation and refer families more than once, on that second referral, the re-referral, they may be more likely to enroll in care, which is what we want. We want to be able to provide the service and support families to be as healthy as they can be. So with that, that's a lot of talking. And I'm happy now to transition over to Nicole, where she's going to talk about our next project.
Thanks, Geoff. So I'm going to talk a bit about predictors of referral. So this is the follow-up study to the paper that Geoff just walked us through. So we published this paper in Family Practice, and it's actually the paper that PCMCH found when they invited us to speak with you guys here today. So overall, we had two main objectives. So first, we wanted to determine the proportion of physicians that referred eligible children to pediatric weight management. And then second, we wanted to determine the predictors of those referrals within Alberta. So we accomplished this through a retrospective population level study, and similar to the study that Geoff discussed. So the data for this referral study included pediatricians and family physicians eligible to refer children 2 to 17 years old from January 2014 to December 2017. So the age range and BMI threshold are the eligibility criteria to refer children to one of the 3 pediatric weight management clinics in Alberta. And then the data included record level socio-demographic data, so year, age, country of graduation, and that's maintained by Alberta Health Services and Alberta Health. And then we conducted descriptive statistics and regression analyses, both univariate and multivariable, using SAS. And so one of our major findings, that first one there, was that only about a third of physicians, Alberta physicians, referred eligible patients to pediatric weight management, and in particular was 35.2%. And this here is just a nice little article that University of Alberta did like a little feature on us. So in total, just shy of 4,000 physicians were practicing during the study period. And in the table, you can see the differences between those who did refer and those who did not refer. So of those physicians who refer, which is about 1,400, almost 90% worked in urban settings, and about 80% practiced as family physicians. So country of graduation, years since graduation from medical school, these didn't have any differences between physicians who did refer versus physicians who didn't. And then in this table, you can also see our univariate model, which showed that compared to their counterparts, female physicians who graduated from Canadian medical schools, and physicians working in urban clinics had greater odds of referring children. And then when we did, like Geoff was saying, well, we want to know how all that interacts together. When we did the final multivariable model, it showed that female physicians, pediatricians, and urban-based physicians still had higher odds of referral. So in particular, females had about a 1.7-fold greater odds versus males. Pediatricians had almost 5-fold greater odds versus family physicians, and physicians working in urban clinics had almost 2-fold greater odds versus physicians from non-urban clinics of referring children. And then I'm just going to talk a little bit about how to support referrals. So first, we speculate that the limited awareness of multidisciplinary services for pediatric weight management may partially explain limited referral practices based on data from the US. So we know that when they have awareness of pediatric weight management, it increases their referral weights to almost 90% for some studies. So first and foremost, increasing awareness of pediatric weight management programs across Canada is needed. Second, physicians have reported feeling a little bit uncomfortable discussing weight-related issues, as well as sometimes ineffective in their ability to treat and manage pediatric weight. So this could be due to limited time constraints or limited resources. So really not only increasing awareness of available services, but increasing training on weight-related conversations may benefit referral practices. And then point 3 here, so studies have found, lots of studies have also found that family physicians have lower odds of referring children to specialty services in general. So this could be because pediatricians have specialized training in children's health, knowledge of clinical practice guidelines for children in particular, and awareness of those services that are available. So increasing the perceived value in screening and referral options, particularly for family physicians, could be of benefit. And then finally, urban-based physicians were much more likely to refer children, and physicians practicing in rural areas can face additional barriers. So whether it be limited resources, training, or lack of tertiary care services. So for example, we know that the majority of pediatric weight management programs are situated in urban centers. So ensuring equity and access to pediatric weight management is really important. And as was highlighted by the pandemic, so telemedicine might be a really promising avenue to increase that equity associated with geographic distances for families and physicians in rural areas. And that takes me to the end of my part as well. Geoff and I want to thank PCMCH for inviting us today, and we want to thank everyone for their time. And we also want to recognize our funders who supported all of this work over 5 to 6 years. And we're happy and we're looking forward to discussing any questions or comments that you guys have. We left a lot of time for questions and comments.
Thank you so much. That's great. That was a wonderful presentation, and thank you for sharing the results and outcome of your studies with us. So we'll now open it up to questions. So and feel free to type in any questions you may have in the chat box, in the Q&A box that's located just under the bottom of your screen. We'll give it some time for people to share their questions with us. Maybe in the meantime, I can ask a question, if that's okay. So I know you mentioned that only 1/3 of referrals, eligible patients are getting referred to bariatric care, and these are mostly in coming from our urban settings. And I know, are there some strategies that maybe your programs are implementing or are thinking to implement just around encouraging physicians that are in non-urban settings? And I know you mentioned that equity and access is obviously a part of that. And are there any other strategies that practical strategies that, in the short term people could start thinking about encouraging physicians?
Well, Lisa, I'd say normally I'm a glass half full kind of person. But during the pandemic, one of the clinics actually closed. Not because people were being reassigned to other duties, which is common, I think, across most hospitals and children's hospitals, but because it wasn't deemed a priority by our hospital leadership. So I don't think it's controversial to say that, but of course, hospitals have to make decisions on how they're going to fund and support a variety of different programs. It was one that they felt they didn't want to continue supporting. So our children's hospital now is one of the few across the country that doesn't have a dedicated multidisciplinary service for children and families with obesity. So, so with that as the context, the brief answer to your question is no, because we have fewer resources. We don't have people in positions that can be out in the community doing planning a lot of the work that's going on now is exclusively clinical. So not, we had positions in the past at our clinic that would be out in the community doing community outreach, connecting with public health nurses, connecting with family docs, doing that groundwork and relationship building to raise awareness of the services. And I think since this study, it's probably gotten worse because the continued relationship building and connections on how do you refer and what happens after the referral and what happens at your clinic, all those kinds of conversations. There just isn't the resource dedicated to doing that now. So it's kind of a sad evolution of how things have gone, but it's the reality.
Thank you, Geoff. I see questions. So let's get started. The first one is, you talked about barriers and making it simpler to refer and get involved. How have you found introductory mandatory orientation sessions helpful or not?
Yeah, great question. So this is one of those things, I'll give you a little bit of a story. So when I first started, I had a lot of experience doing research, and what we would do before research studies is we'd recruit or we'd advertise, and then we invite people to an orientation session, give a whole blurb. This is what we do, how we do it. If you want to participate in the study, sign your consent, blah, blah, blah. And then they would continue on. Some would continue on, many would not. So when we started our clinic in Edmonton back in 2005, that's what we did because that's what we knew. And there was a long wait list of families waiting for service because they didn't have a service up until that point. And that's how we ran it. And then for 8-9 years, at that time, very uncritical thinking about like, why are we doing it this way? We were doing it that way because that's how we always did it. And then I remember we had an epiphany one day as a team meeting. We said, why are we doing this group orientation once a month and making another hurdle for families to organize their lives so they can come to this 2-hour session to learn about obesity and meet us and all these things? Why don't we just simplify it and have our nurse give a family a call after they're referred and try to get them in ASAP? And so we did a little quality improvement project, and it reduced the wait time by about 50%. It increased enrollment by about 20% by taking that mandatory step out. And it was one of those moments where it was like why were we doing it the same way? We were doing it because we weren't really thinking critically about what we were doing and what the purpose of it is. Is the purpose to help the healthcare professionals do their job and hoping that, okay, if families can get things organized and come to this mandatory session or fill in some mandatory forms, that's a way to demonstrate motivation. Well, I'd argue that that's not necessarily demonstrating motivation. It's demonstrating, okay, this is what I need to do to jump through the hoop to get in. You want to make sure they get in in my opinion, as easily as possible. Then they'll learn about the service and what's available, and they can figure out if it's suitable for them or not, or if they have the readiness, willingness, and motivation to participate in a program that's probably long-term, that's helping them over an extended period to make healthy changes and work with the family in that sort of way, overcome whatever barriers they have beyond the barrier that we're putting up as a start as a healthcare system. So I've got a I don't want to say biased, but I think informed by our experience and informed by some data that we need to shrink that time, reduce whatever barriers we have to get families in and try to support them the best way. For years, we thought about how we could help, how it would be helpful for us as a clinic and as clinicians. And then when that orientation switched, how is it better for families? Then it was a no-brainer to do that.
Thank you. Next question. Thank you. Thank you to you both. Really interested to hear more about decreasing wait times. Can you speak more specifically about strategies you are finding that's working for your clinic?
Yeah. So again, these are historical because we don't have a clinic anymore. So we did a few things that reduced wait time. So we have 3 clinics. Another little bit of a tangent. We had 3 clinics when we first started this project. There was some reservations about naming the clinics. You'll notice, and you may notice from the analyses, I didn't say, this clinic had a shorter wait time than the other clinics. I can tell you from behind the scenes, there was variability between our clinics in terms of wait times. But because folks at the different clinics were a little bit uncomfortable with naming them and feeling like there might be some negative consequences to that, we, in the end, combined it. So it doesn't mean that it's wrong, but it was an analytical decision that we made that met the needs of people who were part of the team. So we all did things a little bit differently in terms of the steps. So there's one referral portal to get referred. So physicians would send a 1-page referral in. It gets received by one person for the whole province for these 3 clinics, and then it gets farmed out to the 3 clinics depending on where families live geographically, or physician preference that they go to one clinic or the other. But then the stuff that happens after that was very variable. So I gave the example of how we changed our group orientation because of our experience. The other 2 clinics did not change for a number of years. They kept doing it the way they were doing it, and there's no oversight at the provincial level to say, okay, this is how you're all going to do it. There was a lot of autonomy clinic to clinic, which is good and bad, right? It's nice to have control, but it's also not great for standardization, especially for families across the province when you're trying to achieve whatever sort of thresholds or targets for referral wait times. So the things we've done, I can talk about our clinic at the Stollery Children's Hospital specifically. To have our nurse be the point of contact for families after they're referred was really valuable. For a number of years, we had the same admin assistant. I think 10 years she was with our clinic. She was wonderful. She was that point person. And so when families have the conversation with Roseanne, first off, they come to the clinic, there's Roseanne at the desk, like they've got a relationship right away. We've done some work at our Stollery Children's Hospital around ambulatory care in general. And when there are automatic calls that go out with a robot or computer voice, families hate that. So they often will ignore those calls. Or if you've got a call center where you maybe have 5 or 6 or 7 different people fielding calls and booking appointments, they often feel disconnected to the clinic. So there have been activities at our children's hospital, have those admin folk be more connected to the clinical programs. And this isn't just in obesity, but it's in diabetes, nephrology, respirology. There's a real move to try to connect those groups because they are quite far removed from one another. So if you have the relationship, that seems to really matter for families because there's someone there that knows them, knows a little bit about them, that they care, that they can have that connection. So I'd say that is a practical, like that does not take a randomized control trial to figure out that families might appreciate a real person rather than, a recording or a robot call. So that's one of the things. We've also at a time had a social worker within our clinic. So when the nurse would have that phone call, we certainly probe around potential barriers to participating. So we would have, this is before Uber and Lyft, we would have taxi coupons that some families could use. We would provide public transportation support. So passes for the bus to get there, parking support when families would come, because of course, a lot of us work at hospitals where it costs, $10 or $15 to park for not a very long period of time. So those are often common barriers for families. So those are some of the things that we've done over the years. We also developed a website, and we had all information on the website. So that would reduce the need for the nurse to go over all the things that the clinic is about, because she would direct them, okay, if you want resources, it's all on the website, it'll describe everything. So then she could focus on some other things during those calls. So that was certainly more efficient for her to have some of that stuff done upfront.
Great. Next question is, what were your thoughts on finding that higher BMI was associated with lower enrollment? One might think it would be opposite.
Yeah, it surprised us, to be honest. But then when we thought about it, we thought, well, who are those kids that have severe obesity? And oftentimes, well, the boys and girls that get referred to our clinics in Alberta, I think it's probably not that different in other places. A lot of them have severe obesity. The CanPower study that some of you are probably familiar with, that Catherine Morrison has led for a number of years out of McMaster. I think 2/3 of boys and girls in the CanPower study, there's 1,600 boys and girls included in that project. 2/3 have severe obesity. So we know that there are lots of other things that come along with that. So whether there are social issues, psychological issues, medical issues, other sorts of complexity related to severe obesity, and that it's not just at the level of the child, but there may be issues within the family. It's not surprising that there may be some other things going on. The other thing that we didn't probe in the study, these are administrative data, so we didn't have the opportunity to ask questions around referrers, so the docs as well as the families that were included in the studies that Nicole and I talked about. But it would not surprise me at all if issues related to bias and stigma and the experiences that families have had, past experiences they've had with healthcare professionals, and the fact that they live in big bodies had an impact on whether or not they felt like they would be supported and helped in the way that they would like to be helped at these clinics. So again, not a very positive message to share, and that's not unique to the healthcare system. In Western culture, we do not value people who live in bigger bodies. That's the bias and stigma that permeates our lives. So that's the challenge for the families that we face, for sure. So to be mindful of that and to do the best that we can to help everybody who's referred, I think that's our challenge.
Thank you, Geoff. Next question. Thank you for your presentation. Is there a list of current pediatric bariatric programs in Canada?
That's a good question. We did a survey over 10 years ago of all the clinics in the country, and at the time there were around 20. There's certainly more now, especially in Ontario, with the increased funding that has been allocated by the ministry, which is great and clearly needed. There's clearly a demand for it. Obesity Canada I think Obesity Canada had at one time a map mostly focused on adult obesity services. As far as I know, there's no current up-to-date directory of clinics across Ontario or the country. I may be mistaken about Ontario. Maybe that's a bit better organized because of the investment of the ministry, but nationally, not that I'm aware. But I think it's safe to say, from what I know, there's no service that's multidisciplinary in Saskatchewan, Manitoba, Maritime provinces. I don't think, as far as I know, the service. So it gets back to Nicole's point she mentioned about equity. Really, availability and accessibility is a challenge, and it's not unique to obesity, right? And there's lots of other areas where that's a challenge in a big country like Canada, but we feel it because we get referrals from all over the place, and families are far away, and it's challenging for them to be well supported in the way that we would like to support them.
Thank you, Geoff. So just to jump in, we do have a directory for the Ontario programs. Currently we have the 11 programs across Ontario, but I guess the question was more on a national level across Canada. Next question. Some pediatricians, MDs, get upset when families are not engaged in the full multidisciplinary program and feel follow-up should be reserved for those who follow the program. Although we know that, family situations are at risk, are risk factors for obesity and timing, geography, etc. Can all barriers, this is a frequent challenge. Any advice on how to best manage this?
I'm not sure, Lisa, I gathered the question out of that. There's a few points raised around the issues.
Maybe we can come back to that question.
Okay, thanks.
We'll go to there's a comment. I guess this one is more of a comment. I'm a pediatrician in Toronto. My population is struggling with wait lists, too many investigations prior to referral, and most patients have no good experience. More of a general comment.
Yeah.
We have another one. Do you think the transition to more virtual care has been beneficial to families as part of the pediatric programs, bariatric programs, by making them more accessible in many ways? In my clinic, and I'm a dietitian, there has been a push to transition to in-person education sessions. Can you provide any insight on this?
Mm-hmm. A great question. So I would, if I was in a position to make decisions on how we orient our health services, I would say, well, what does the data say? What's the evidence that says virtual care is superior or as good as in-person? If you have it's difficult to collect those sorts of data, right? There's CIHR has had calls for funding applications around virtual care, not just in obesity, but across, sort of across child health and adult health. And to my recollection, there's no data that says that virtual is superior, but if it's non-inferior, it's just the same as in person. It certainly could it could improve accessibility, could improve availability. You think about all the barriers that families experience in accessing care, taking time off work, taking time away from school, traveling, childcare. all those things. Many of us have pretty luxurious jobs where we've got some flexibility. Lots of families don't. So for those families that may be more at risk or maybe have less advantage, then providing that sort of care can really be a game changer for them to be able to access care because of all the other things that I mentioned. So I think to have that as part of the suite or part of the menu of services makes a whole lot of sense. The push to get people back in person, I would want to know, well, what's the motivation? Is the motivation because people are demanding it? At the end of the day, we're providing a service as healthcare professionals, and our customers are the people who refer to us, and families. So I would be surprised if families still did not want to have that option. I know physicians that I've talked with really value and really missed over the pandemic, really missed the opportunity to see people in person, kids in person, to do physical assessment, to screen for potential obesity-related comorbidities. And it seems like that's a really critical piece. But beyond that, can virtual care or follow-up replace a lot of the other in-person follow-ups that we used to do? Potentially. But again, I think we should be driven by evidence to say that this is going to be helpful. Maybe the decisions at the end of the day are practical, and they're practical because you need to do whatever for the healthcare, from the healthcare system perspective. But I would think about what's in the best interest for families. If we don't have evidence to say one is superior over the other, what's in the best interest of families? That should be driving it.
Thank you, Geoff. So this is all the questions we have today. I just want to thank you both, Nicole and Geoff, for the wonderful, insightful presentation and talk. And thank you, all of you. Thanks to all the participants who joined us today. Just as a reminder, you will receive an evaluation survey, I believe, tomorrow. So if there's any feedback you can provide us with respect to today's talk and any future topics that you would like to see presented, please do let us know. Once again, thanks everyone, and have a great afternoon. See you all next time. Bye-bye.
Thank you.